Welcome back to the deep dive. Today we're getting into something that, well, if you're preparing for high-stakes exams, you absolutely need to know this inside and out.
It's a big one.
We are cutting through a seriously dense stack of material GMC guidelines, legal summaries, SJT revision notes, all focused on one thing: consent to research.
And this is an area where the rules can feel very black and white on paper, but the clinical reality is, well, it's just shades of gray, isn't it?
Exactly. So our mission here is to translate all of that complex text into the actual things you need to do, the actions that define a safe, high-scoring doctor.
Let's do it.
Okay, let's just jump straight to the pressure cooker. A scenario the SJT absolutely loves. Imagine you're in the emergency department. You have a patient, critically ill, unconscious, but they are a perfect match for an approved clinical trial. A CTIMP, in fact.
Right, a clinical trial of investigational medicinal products, so
Yeah.
high stakes.
Very high stakes. It could genuinely save their life. But you can't get hold of their next of kin. You have minutes to decide. Can you enroll that patient? Can you start the treatment?
And you can feel the tension in that question, can't you?
Yeah.
The answer is a conditional yes, but it's a huge but.
Okay.
You can only proceed if the Research Ethics Committee, the RVC, has specifically pre-approved this exact kind of recruitment for patients who lack capacity.
So you have to know that approval exists.
You must. And if it does, you can proceed. But your immediate next priority is to get consent from the right person, a legal representative, or the patient themselves if they wake up as soon as you possibly can. That's not optional. It's mandatory.
That sets the scene perfectly. So if we had to boil it all down, all the legal jargon, what's the one core truth about research consent we need to hold on to?
It's this. Consent in research needs three things to be valid. It needs capacity, it needs full tailored disclosure, and it needs the absolute freedom to withdraw. That's it. Patient autonomy and safety always come first, no matter how great the research seems.
So why does the GMC focus so heavily on this? I mean, it feels a step beyond standard consent for treatment.
It is, because research, by its nature, involves uncertainty. It has to. And that raises the stakes. The GMC links this directly to good medical practice. You have to be satisfied, you have valid authority before you involve anyone.
And a failure here is a big deal.
A huge deal. A serious or persistent failure puts your registration at risk.
And for someone sitting the exam, what's the pattern they should be spotting in the questions?
They're always testing the balance. It's beneficence, though, the potential good of the research versus autonomy and capacity. The patient's rights.
And the traps?
The traps are always about diminishing those rights.
Yeah.
Assuming someone understands, or maybe subtly pressuring them not to withdraw. Those are the low-scoring options every single time.
So it's that ethical line you cross when you move from pure treatment to investigation. That's what's being policed here.
Precisely.
Okay, let's get into the core principles. You mentioned 3 pillars of valid consent.
Yes, and if you can visualize these, you're halfway there.
Let's get the mnemonic out there straight away.
Good idea. It's simply ICV,
ICV.
informed,
Yeah.
capacity,
Yeah.
and voluntary. If any one of those 3 pillars crumbles, your consent is invalid. It's gone.
Let's break those down. I for informed. The sources really stress that this isn't just about giving someone a leaflet, is it?
Not at all. It has to be comprehensive. And the key word is tailored. You have to actively fight against making assumptions.
What do you mean by that?
Well, you can't assume what someone knows. If there's a language barrier, you get a professional interpreter. If they have a learning disability, you use simple language, you use aids. The safest doctor is the one who actively breaks down those communication barriers you check for understanding.
Okay, and V's for voluntary. Let me push back on this a bit. With a real-world problem,
Go on.
a patient agrees to a trial. Halfway through, they want to withdraw, but their data is critical. The whole study might be compromised. Does the research value ever override their wish to pull out?
That is the perfect question. And the GMC's answer is an unwavering no. Never. The right to withdraw has to be explained right at the start, and it must be respected at all times, without question. Their decision can't affect their normal care or their relationship with you. That is a non-negotiable professional standard.
And what about the risk for the doctor running the trial, especially if they delegate getting consent?
Delegation. You're still accountable. If you ask a junior colleague to get consent, you have to be sure they are competent, that they properly understand the protocol, the risks, the benefits.
Because if they mess it up...
It comes back to you. The responsibility is yours.
Okay, let's put this into a clear action flow. First, next, last. What are the absolute must-do steps?
Right, a simple, safe process. First, you assess and inform.
Capacity first.
Always. Confirm they have capacity. Then give them the tailored information, risks,
Yeah.
benefits, the right to withdraw. Make absolutely sure there's no coercion.
Okay, step 1. What's next?
Next, you record and notify. Get the consent and record it. And if it's a CTIMP, one of those drug trials written consent is a legal requirement.
Not just good practice, it's the law.
Exactly. Then you should normally let their GP know.
And last?
Last, you manage any objection to sharing. If the patient says, I don't want my GP to know, you have to respect that. The only time you could override that is if sharing was, overwhelmingly in the public interest. And for research, that is a very, very high bar. Autonomy usually wins.
We've got the ICV mnemonic for the pillars. To really make that stick, I want you to picture those 3 letters as solid marble columns.
I like that.
If any one of them gets a crack or starts to crumble, the whole structure, the consent itself, just collapses.
That's a great visual. And for a behavioral hook, just remember this phrase. Research involvement must not affect standard care.
Simple.
In an SJT, if you're ever in doubt, pick the option that protects the patient's normal clinical relationship over the needs of the study. That's always the safer bet.
Let's walk through some of those tricky populations, starting with adults without capacity, but in a non-emergency. This is where the law gets very specific.
It does. For a start, the research has to be about their incapacity or a condition that causes it. And in England and Wales, you have to consult a designated consultee.
Who is a consultee, exactly, for anyone who doesn't know?
It's someone who advises on what they think the patient would have wanted. It's often a family member or friend. But here's the critical point. They have veto power.
A veto?
Yes. If the consultee believes the person would not want to take part, or even if they're just really unsure, you must not include them. End of story. Their role is to protect the patient's presumed autonomy.
Got it. Okay, next pattern. Children and young people. What's the test here?
It's balancing parental consent with the child's own views and developing competence. You always need parental consent, ideally from both parents if it's higher risk.
What if the parents disagree?
Then you shouldn't proceed. The only very rare exception is if the research offers a treatment that's literally unavailable any other way and you assess it's truly in the child's best interest. Even then, the safest action is to pause and seek legal advice.
And what about those CTIMPs again? We know about written consent, but are there other legal landmines?
Yes, a big one is incentives. You must know that offering incentives, so anything beyond reasonable compensation for time or travel, is legally prohibited for minors and their legal representatives in CTIMPs.
So no cash bonus to encourage them to sign up?
Absolutely not. That would violate the voluntary pillar.
Let's talk about the common traps. Where do good doctors get these SJT questions wrong?
The traps all test your commitment to ICV. I'd say there are 5 common ones.
Okay.
First, delaying the discussion about withdrawal. If you only mention it after they're enrolled, it looks manipulative. You have to be upfront.
Second,
offering a financial incentive that isn't just compensation. As we said, giving a kid a cash bonus for a CTIMP is illegal. It's undue influence.
makes sense.
Third, proceeding when the consultee is unsure. If they say, I just don't know what they would have wanted, you have to stop. Ambiguity means you default to protecting the patient. You don't include them.
What's trap number 4?
Making assumptions about understanding. You see a participant who's, say, a lawyer or professor, and you assume they get the methodology. You can't. You still have to tailor the information and check they've understood.
And the last one?
This one's maybe the most serious. Ignoring nonverbal cues from patients who lack capacity.
So what does that look like?
If they look distressed, if they're pushing you away, turning their head, any sign of objection, spoken or not, must be treated as a refusal. You withdraw them from the study immediately. The Mental Capacity Act is crystal clear. Silent objection is still objection.
Okay, let's lock this in with some rapid-fire actions. If X happens, you do Y.
Sounds good.
If a vulnerable adult who has capacity seems hesitant.
You must pause and check if they need more support, maybe an advocate, or just more time. You don't push on.
If a participant loses capacity partway through a trial.
You must follow the law. That usually means immediately finding a legal representative or consultee to get consent for them to continue.
And if you're designing a study that uses human tissue.
You must comply with the Human Tissue Authority codes. That means getting really specific consent for how that tissue will be stored and what it will be used for.
This has been a really effective breakdown. Let's wrap up with the 3 key takeaways you need to remember.
First, the pillars. Remember, ICV-informed, capacity, and voluntary. If you're ever unsure, your default action must always be to protect the patient's autonomy.
Second,
Special populations have special legal safeguards. That means REC approval for emergency research, Consultee involvement for adults lacking capacity, and always getting written consent for CTIMPs.
And thirdly,
Your professional conduct. It's all about tailoring information, avoiding assumptions, and making it absolutely clear that withdrawing from research will never, ever harm their ongoing care.
it's clear that applying these standards in the real world takes good judgment, doesn't it? You have to ensure patient dignity isn't lost in the rush for data. So here's a final thought for you to take away. What scenario in your own field might test that fine line between research benefit and patient autonomy next week? Are you ready to justify stopping a study because a nonverbal patient seems distressed?
Because that's the ultimate safeguard. It's not just knowing the rules, it's being able to stand by your decisions and explain them using this guidance. If you can do that, you'll always be on the safest, highest scoring path.